Pulmonary was treated for asthma and had no benefit in his symptoms. Then he saw ENT probably 3 to 4 months prior to us seeing him. They scoped him down to the level of the cords and didn't really see anything. So he sort of went along and continued to have his problems. He had an endoscopy looking for GERD or looking for changes in his mucosa to suggest GERD. Tolerated that okay. They didn't find anything, but he tolerated the sedation okay. And then he had a CT scan done a few weeks prior to his presentation because things were, quote, just not getting better. And again, he's otherwise healthy and his exam is unremarkable, except he also has sort of this inspiratory and expiratory wheeze or stridor that you hear over his trachea. More so with forced maneuvers. So with just normal tidal breathing, he didn't really have any problems. So again, so he had his PFTs 3-4 months prior to us seeing him, and he also has this flattening of his expiratory limb, of his flow volume loop. And then these are his PFTs when we saw him. And now he has flattening of his inspiratory limb, and then he sort of has this oscillating look to his expiratory limb. And so we can see that with upper airway obstruction or with airway obstruction. We can see it with sleep apnea. But we can also see it with obstruction where you sort of got soft, floppy tissue, where you sort of have air that's going against it and tissues kind of moving around in the airway, so not necessarily a fixed obstruction. So he went and saw ENT initially. They did a laryngoscopy on him, and this was his CT from about a month prior, and then they put a scope down, and this is what they saw. So that is a little bit alarming. Again, he came in and he looked good. He walked in, he was not on oxygen, he was not in distress, he was not somebody that you would say, you have something big and bad inside your airway that we need to get out. And so then we ended up scoping him, and it even looked a little bit worse. So there's not really much room here. And again, this guy's walking and talking. And so you see something like this, and you might have this kind of reaction initially. But I think the big thing, again, is you look at the patient. You say, okay, you walked in here off the street. You're doing okay. So we need to take our time and sort of figure out what's going on and make a plan before we jump right in and try to intervene. Because that's when we can get into trouble, is when we rush into things and don't have a sort of plan at the outset. So now the question becomes, so what do we do? So what can we do for these two people? So do we send them home to follow up in a few months? Obviously that's been done sort of several times before, so maybe we should do something more. And then the next three are actually, any one of these could be an answer. So we could do a flexible scope, secure the airway, do some debulking, get a biopsy, figure out what's going on. We could do a rigid bronch, take them to the OR, put a rigid bronch in their airway, secure it, and then do more in the OR. We could send them to ENT for an emergent trach. Let's secure the airway that way, and once the airway is secure, then let's kind of figure things out. And so the second patient that I presented to you, actually the ENT doctor called me and said, this guy walked in, this is what things look like, and really I think I should just take him to the OR, and I just want to trach him. And then he said, well, and then I talked to somebody else, and they said, maybe we should call you guys to see if there's something you could do for him rather than putting him through a trach immediately. And personally, if I walked in off the street and I'm feeling okay, I don't necessarily want a trach as the first thing to happen to me. And so I think knowing that there are other options and knowing that there are things that we can do from a bronchoscopic perspective that we can try, sometimes obviously we fail and we end up still needing to do the trach or doing something surgically. I think it's nice to know that there are other options. So both of these cases are examples of central airway obstruction. So central airway obstruction occurs when you have more than 50% occlusion of the trachea or the main stem bronchi, the bronchus intermedius, or a lobar bronchus. So symptoms may not manifest until there's a critical stenosis of 5 to 8 millimeters, or there's some new event that exacerbates the underlying stenosis. And so when we see patients like this, as we're seeing them or as we're doing the bronch, we're sort of making both a qualitative evaluation and a quantitative evaluation. So we're kind of looking at it and saying, what are the chances this is benign? Do we think this is malignant? What's the mechanism of the obstruction? Is it something that's just in the airway? Is it coming from outside the airway? And then what are the dynamic features? Is it on a stalk that is just kind of flopping in and out, and that's why the patient's not so symptomatic, and it gets in a position where it obstructs more, and that's why they're symptomatic? Is it just a broad-based lesion that's causing obstruction? And then a quantitative evaluation, because the quantitative evaluation will help us decide some of our interventions as well. So how long is it? Where is it located? Is it in the trachea? Is it just in one of the main stem bronchi? Does it involve the entire trachea? And is it multifocal? Is it in more than one spot? And again, the type of obstruction will then dictate what our options are for intervening. So when we look at we'll look at non-malignant central airway obstructions, and then we'll also look at malignant central airway obstructions. So some of the more common things that we see for non-malignant obstructions, so squamous papillomas. So people can get papillomas in their airway that can be multifocal and extend up and down their trachea and up into their larynx, or they can be in a single isolated location. But we see them, I guess I wouldn't say fairly frequently, but we have a good handful of patients that we take care of with squamous papillomas or recurrent respiratory papillomatosis. Trach tubes, so people that get tracheostomies in. Some people, for reasons that are not totally clear, at the end of their trach tubes, they get really exuberant granulation response. Not a lot that we can do about that. We try to kind of maintain patency by debulking what we can or trying to do some cryo or cold-based therapy. And you can't predict who's going to get that sort of reaction, but ENT will sometimes send us patients like that we just sort of see on a frequent basis to try to maintain that distal airway because the trach oftentimes can't come out. Idiopathic subglottic stenosis, so that was an example, the first case that I showed you. Sarcoid can involve the airways, so we can see stenosis in the setting of sarcoid. Post-radiation, so this is a risk that's discussed with patients who have malignancy, but oftentimes at the time that you're diagnosed with cancer and you're going through your treatment, your goal is to get rid of the cancer, treat the cancer, and sometimes don't always hear that you can get post-radiation stenosis, you can get radiation pneumonitis. So this can be a really big problem for people because their malignancy is perhaps cured or they're in remission, but then they're left with a lot of the bad effects related to radiation. So we can see stenosis related to that. And then post-transplant, as we kind of talked about. So at the anastomosis, we can get stenosis that sometimes needs intervention. So from a bronchoscopic standpoint, I think it's useful to look at sort of ablative techniques. So what can we do to get rid of tumor or mass, and then what can we do to then maybe open the airway more? So when we look at the ablative techniques, the top three are heat-based therapies, and then there's cryo, which is obviously cold-based therapy. Brachytherapy would be radiation therapy, so we can do focused radiation in the airway. That can be a fairly involved procedure, and then photodynamic therapy. So YAG laser used to be used kind of more often. We used to do it at the university fairly often, but we've sort of moved away from it. Often needs a rigid bronchoscopy. You need laser training, most often done in the OR, and it can be fairly pricey. You achieve good results with opening up the airway, and what happens is you can achieve coagulation and vaporization of tissue. And you probably get a little bit deeper treatment than you get with electrocautery or argon plasma. So probably more of what we use is electrocautery. So you get a bit more superficial coagulation. It's pretty safe. We can do it through our flexible scope. We have a variety of tools. So again, it's heat-based therapy. You get an immediate effect. You have a tumor obstructing the airway. You can use a heat-based snare. You can use a blunt probe to kind of cauterize and coagulate the surface and then do sort of debulking of the surface and then keep going deeper and deeper. And again, you get similar results compared to laser with probably less cost and maybe less invasive procedure, less lengthy procedure sometimes. And then argon plasma coagulation is again kind of superficial. We can do it through the flexible scope. It's very safe. And again, it doesn't go too deep, so you have to do sort of several cycles. But again, all of these are fairly similar in terms of the improvement that you get in the airway diameter. The things that you have to think about when you're doing heat-based therapy, so heat and oxygen don't mix very well. So if you have somebody that's requiring high amounts of oxygen, we're limited in using our heat-based therapies because we run the risk of an airway fire. So we sort of prepare for that and we take oxygen off, and if somebody is requiring oxygen, we just do something else like cryotherapy. Obviously they have to have a grounding pad on, and the risks of any of the heat-based therapies would be risks of bleeding, risk of perforating the airway wall. But again, you're balancing the risk versus the benefit. And then cryotherapy, cold-based therapy. So this does not give you an immediate effect unless you put your cryo probe on, you freeze it, and then you pull your piece off. So do like a cryo biopsy. Most of the time, we're just doing it, again, to kind of maintain things or control things after we've done some heat-based therapy. So you get delayed tissue destruction over a couple of weeks. It can also be very useful retrieving foreign bodies. So if you have a foreign body, or if you have a bunch of impacted mucus, or if you have blood, you can freeze it and then try to pull it out that way. That's actually a very useful tool. And then brachytherapy and PDT we won't talk too much about. And then once you've debulked and opened it up some, then balloon dilation can play a role to kind of open things up a bit further. So in most patients, the rates of immediate success with the balloon and then short-term success are pretty high. So you balloon it, you see that it's better, they feel better, but then long-term success can be somewhat unpredictable. So for some of these patients, particularly patients with the subglottic stenosis, they require multiple procedures. So we kind of go in, make some cuts, dilate them, and then bring them back a month later, 6 weeks later, and kind of do it again, and do that in several cycles. So we try to get their airway, up to sort of a new size for them, and then you can kind of space things out after that. It's less successful in situations where you have malacia. So we'll sometimes get people sent for tracheomalacia or bronchomalacia. Those you kind of just have floppy walls, or you have cartilage that's sort of lost its structure and an airway that's lost its structure. You can't really dilate that and keep it open very well. So the balloon doesn't tend to work very well in those situations. So this is what the balloon looks like. So we have these variable sized balloons. So we have one balloon that we can dilate to several different sizes depending on how much saline we put into it and what the atmospheres are. So that way, just with one balloon and in one sitting, you can sort of get a gradual dilating and opening of the airway. So this is the balloon inside somebody's trachea. And you sort of have to warn them, because we do these generally under conscious sedation, so they're spontaneously breathing. So obviously you inflate the balloon and you're totally obstructing their airway. So in order to do these in the bronch lab with a flexible scope, you need to have somebody who is not terribly anxious about the procedure, understands that they might have to hold their breath, and understands what's going to happen. So you have to choose your patients wisely in terms of who can be done in the bronch lab versus who maybe should go to the OR. So case number 1. So she had a couple of dilations done. So about 8 weeks later, this is what her flow volume looks like now. So she has less flattening of that expiratory limb, and her peak inspiratory flow has gone up about 1 liter, and clinically she also felt better. And so this is what her airway looks like now. So this is one of these radial cuts. So we made a radial cut with heat, so with an electrocautery knife. So you make a cut and then you dilate, and then you can see that that cut kind of flattened out and you got dilation, and the stretch and the split in the mucosa happened in that area. And so she felt better, and we see her about every 6 months or so now. So flexible bronch under conscious sedation. We did initially serial bronchs every 4 to 6 weeks, again radial cuts, and then the serial ballooning. So case number 2, this was what his flow volume loop looked like after we intervened about a month later. So now he has nice normal looking loops, and his peak inspiratory flow went up to 9 liters. So he noticed, so his narrowing was fairly gradual, so he didn't really realize how symptomatic he was until we relieved his obstruction. And then once his obstruction was relieved, like I said, he sort of realized that he'd been pretty short of breath for quite a long time and had kind of adjusted, his activities and things based on those symptoms. And so this is what his airway looked like. So we got that tumor out of there, and then this is what it looked like about a month later, just to survey. And so he had a papilloma. And so looking at his initial image, that's kind of what it looked like. It had that cauliflower look, and those papillomas tend to be fairly soft and kind of floppy and on a stalk, which is why I think he was not as symptomatic and why he kind of walked in off the street, not feeling too badly. And so interestingly, so he had all this kind of stuff that actually looked like a bunch of papillomas on that anterior wall after we took out the big papilloma. And we didn't really do anything to this except what we did to remove the papilloma, and all of that looks much better even a month later. So he's somebody that we'll probably have to repeat a bronch on. Actually, I think he's coming in next week periodically to just make sure those papillomas aren't coming back, because they will come back, and everybody's different in terms of how rapidly and how big they come back. So we're going to kind of move on to malignant obstruction. So this is a 54-year-old woman who presented with increasing cough and mild increased shortness of breath with no improvement. It's kind of a common scenario. She had some weight loss and she had some chest pain, and then she also had some new hoarseness, which raises a red flag. So her imaging revealed mediastinal adenopathy. So this is her big mediastinal mass or lymph node. And here you can see that her airway is open, but it's probably externally compressed, from the outside. Her bronch showed this external compression. She had an EBUS, so we used the ultrasound scope to biopsy that. Now, some might argue that we don't really need the ultrasound to get to that, but we tend to use it all the time. And came back as squamous cell. So she got her diagnosis, and then all of the referrals and consults were put in place in order for her to get treatment started. But then she ended up getting admitted a few weeks later with increased shortness of breath. And so a few weeks later, this is now what her mass looked like, and this is now what her airway looks like. So she's somebody who has more of a critical stenosis and is much more symptomatic. So she